So in these kind of situations, you have to load the patient with steroids and local as well as systemic. General condition of the patient is seen if a patient has multiple organ disease, if he has renal transplant or kidney patient, you are on the side of infection. Also, a good clinical history is taken from the surgeon, whether any complication was there during surgery or not. If there was any complication, that means it's a post-op reaction rather than an infective etiology. Patient of infection usually comes with a typical complaint. डॉक्टर साहब कल तक तो मैं ठीक देख रहा था, पर रात को सडनली आई वोक अप, मेरे सर में दर्द हुआ और मैंने एक आंख बंद करके देखी तो मेरे को दिखना बंद हो गया. If the patient comes with this history, the spot diagnosis is infection, and you have to take this patient for intravitreal injections. But this cardinal sign of pain is only there in 70% of cases, not all patients. Uh, you have to look at vision. If the vision is good, then usually the infection, the reaction is sterile. But if the vision is poor and there is a sudden drop in vision, are on the side of infection. If you have an angry looking eye, severely congested with pain, you are on the side of infection and a diagnosis of infection is made. Intraocular pressure is usually high in sterile inflammation in lesions like in disease like TAS, and low in infective disease because of the severe inflammation. The IOP will be low. Then a careful examination of the wound integrity is done. If you see a weak wound, phaco burns, vitreous in the wound, if you see an exudate in the wound, blebitis, the diagnosis is infection, and you go ahead and give intravitreal injections. Hypopion means there is a severe inflammation in the eye. The reaction is 4 plus, and because of the 4 plus reaction, there is a deposition of these macrophages. And if you have a dark brown hypopion, then it's a sterile. Yellow or white hypopion is usually infective. Important thing, if you have an hypopion in your patient, you don't have to let this patient go. Make this patient sit in your OPD and monitor it every 2 hours. Ask your OPD attendant to dilate the patient, put antibiotic drops and steroid drops hourly, and still you see this hypopion is progressive, then it should be considered infective. Pupillary dilatation, according to me, is one of the most important signs to decide whether it's a sterile inflammation or it's an infective inflammation. Uh, what you have to do if the usually patient comes with a constricted pupil, you ask your attendant to put dilating drops at every 15 minutes. Even you can give subconjunctival midricaine. If you are able to break this fibrin membranes or dilate, you can see peep into the retina and you will be able to diagnose whether it's an infective or an inflammatory pathology. But if this pupil does not dilate, then err on the side of infection and give intravitreal injections. If you have an absent glow, that means it's an infective, or if you see any signs of exudates in the vitreous cavity, it's an infective and it's clear-cut signal for you. Go ahead and treat this patient as infective. In sterile inflammation, the glow is good. Many times, once you are not able to diagnose, peep into the retina, whether the retina is good or you are not able to see the vitreous, then you will have to do an ultrasound. And if you see exudates like this in the vitreous cavity, the diagnosis is spot on infective. TAS is usually presents within 12 to 24 hours. There is a severe corneal edema, that is limbus to limbus. There is a dilated pupil. AC reaction is moderate to severe. There is an high intraocular pressure, and the disease is restricted to the anterior segment. Usually, the cause of TAS is reactions to abnormal solutions, contamination of equipment, denaturated viscoelastic, residual detergents, intracameral anesthetic agents, preservative in topical medication. But 90% we are still not able to find out what is the cause of TAS. And if you have it suspicion of TAS, then patient is put on hourly topical steroid under daily supervision, and IOP is monitored, and you will start seeing improvement within 24 to 48 hours. If you don't find any improvement within 12 to 24 hours, then think of infective etiology, don't think of TAS. We'll see some examples here. This is one of the patients. You can see RK has been done. 1 day post-op, there is a very severe fibrinoid reaction. It is, but no hypopion. We started this patient on hourly steroid. Day 2, you can see there is a retraction of the fibrin membrane. Day 5, the fibrin membrane has retracted. And day 14, the eye is absolutely quiet, and the patient comes with 6/6 vision. This is one of the patient. You can see there is an hypopion. We gave intravitreal injection of vancomycin and ceftazidime. The hypopion disappears by day 5. And generally these patients, we start with systemic steroid once the hypopion disappears. And you can see day 10, the pupil is dilated. You can see a good fundal glow. And this patient also improved with a very good vision. This is an interesting patient. You can see almost a quiet anterior segment. There is no reaction. But why I wanted to show this patient is there's no glow. Next day, 1 day post-op, this patient came with a finger count vision. We examined the pre-operative records. The vision of the patient was 618 pre-operatively. So once you don't have a fundal glow, that what I said before, the diagnosis is spot on, that is infective. Immediately we took the patient to operation theater. Here you have to decide, a decision has to be taken of intravitreal injection immediately, because if you delay this patients will land up with vitreous surgery. So we gave intravitreal injections of vanco and ceftazidime, and you can see within 20 days you can see 6/6 vision. Anterior and the posterior segments are good. This patient, we gave intravitreal, but patient didn't responded. So we went ahead and did an IOL explantation with a base dissection, and these are the post-operative results with 624 vision, and we were able to salvage this eye. Uh, Coming to chronic endophthalmitis, this patient, if you see here, you can see whitish deposition on the posterior capsule, had incidence of recurrent inflammation. Each inflammation used to subside with steroids and posterior subtricot, but it bounced back the moment the effect of steroid decreases. It bounced back with vengeance. And after 4 to 5 inflammation, we saw the posterior capsule, and we realized this is not simple inflammation. This is P. acne infection. And for P. acne infection, you have to remove the IOL with capsule, and we did the same, and the patient is having 6/6 vision. After 6 months, we took the patient again for surgery, did scleral fixated IOL, and patient now is enjoying with 6/6 vision with glasses. Uh, in fungal endophthalmitis, if you see this cotton ball opacities with vitreous haze, the eye is relatively quiet in fungal endophthalmitis. And these cotton ball opacities, the diagnosis, what you get is candida infection. And these patients will not benefit with intravitreal injections. You will have to give intravitreal voriconazole, that is Voritech, followed by a vitreous surgery. because these patient requires multiple injections. One injections will not benefit this patient. The, even with all this information, many a times there are patients we are not able to decide whether this is infection or inflammation. So what we do is, in doubt of excessive inflammation, start intensive therapy with steroids, antibiotics. Antibiotics you have to choose gram negative and gram positive. So we start with moxifloxacin with concentrated tobacin. Nowadays we are starting with vancomycin drops. With cycloplegics, usually atropine with tropicamide is preferred. Homide does not dilate the pupil. And other important thing, you have to follow these patients every 2 hours, 3 hours. You cannot let this patient go home and say you come tomorrow and then I'll decide what you have to do. You have to admit, because all our practices are daycare practices. You have to, generally we see our patients in the morning. You make the patient sit in the OPD and ask for hourly drops, and a very close follow-up is done. If it is a pure inflammation, it starts showing signs of improvement within 24 to 48 hours. If infection improvement does not occur, or sometimes small initial improvement and then worsening, you have to consider intravitreal injections. This is a chart of what I have summarized before. If you have pain, that means infection. Surgical manipulation, that is a sterile, you have to give steroids. Weak wound, chances of infections are more. If hypopion is there, white hypopion means inflammation, means infection. Brownish hypopion means uh, in, inflammation. Pupil is poorly dilating, goes in favor of infection. If you have these last two signs are mandatory to determine whether it's infective or inflammatory. If you see no glow or exudates in the vitreous cavity, don't err on the side of inflammation. It's infective, and you have to take the patient to operation theater and give intravitreal antibiotic. So, take home message is sudden deterioration, bad wound, pain, chemosis, hypopion, poor glow with exudates in the vitreous cavity. Think of infective etiology, give intravitreal. If there is a pre-existing disease, surgical manipulation, complicated surgery, hypopion, good glow, eco-free ultrasound, usually it's sterile and you give steroids. Uh, After giving intravitreal injections, watch for 24 to 36 hours. If there is an improvement, continue with medical treatment. The moment the hypopion goes, start your patient on systemic steroids, and after that stage, the systemic steroids starts improving the vision, not the topical steroids. If there is no worsening, continue with the medical treatment, and after a while you see there is no significant improvement, go for a pars plana vitrectomy. If there is a worsening on 24 to 36 hours, take the patient for pars plana vitrectomy with silicone oil. So to conclude, careful history from both patient and surgeon, along with close follow-up and timely intervention, can salvage most of the eye. Thank you very much.
Thank you, Dr. Avnendra. So you covered the subject very well. So you included everything. I have a couple of questions from the general ophthalmologist perspective. What is the role of systemic steroids? So very often we see prescriptions with systemic steroid apart from the topical medications.
Sir, first the infection should be taken care by intravitreal antibiotics. Once you are sure that infection has gone, then only you have to start with systemic steroid. Because there are two parts to endophthalmitis. One is infective, second is the reaction to the endotoxins. Infective part will be taken care with the intravitreal antibiotic. So there are two views into it. Many people give intravitreal decadron, but as a preference, as a group, we don't go for intravitreal decadron at first sitting. Once the inflammation subsides, by second to third day, we start the patient on systemic steroids, and provided the hypopyon is not increasing and the patient is not worsening, and then the systemic steroids improves the patient, because then the inflammation parts comes where the endotoxins and the inflammation due to the bacteria are there, which is taken care by the systemic steroids.
Yeah, thank you. And yeah,
What is sir's recommendation? Would he prefer methyl prednisolone oral or Vizolone in his opinion?
We prefer to give an oral prednisolone, Vizolone only.
Not methyl.
No, we don't give. No, no.
We give oral.
Actually, if you see, you have to titer methyl prednisolone, because if you see the doses of methyl prednisolone and
16 milligrams, 8
very high.
milligrams.
so the calculation what it comes is zero point 0.4. If you 10 milligram is equivalent to 0.4 milligram of 4 milligram of methyl prednisolone. So you can equally calculate methyl prednisolone. If you see the pharmacokinetics, it breaks up into prednisolone only, and the results are almost the same.
Okay. One more thing, see, most of us are daycare center, we ask the patient to, some surgeons ask the patient to come on the next day and some on the 5th day. So what would be the preferred? How can you detect the cases early, and which would be your approach for the first or second post-operative visit?
So one day is mandatory. I think nobody is practicing the second day on if you operate. One day is mandatory. Then you tell your patient if there is a history of pain, congestion, or sudden decrease in vision. I think every surgeon has a note कि if you see any history of pain, sudden decrease in vision, you have to immediately report to the OPT.
Thank you. I think that is very important, because when and how to obtain urgent care, because in the night we may not be available. So we have
But
to
the only caveat
counsel
is
the
that,
patient
don't
properly.
do a telephonic kind of consultation.
Yeah.
If patient has issues, we write SOS, please, then patient should rush. Patient should immediately come. If there is, we write on the discharge card, if you have pain, excessive, watering, or, vision loss, then report immediately. Although you see most of the endophthalmitis come between 1 and 3 days, or 2 and 5 days in fact. So like Nirmal was asking, first day you have seen, then you call patient maybe after a week or so, you can miss in between. So therefore you have to write, please report SOS in case of 3-4 things. Yeah?
May I ask?
Yeah, please.
So, one of our patients, he had not very significant visual improvement post-operatively, initially like up till 10 to 15 days. So, we were expecting that refractive error and like 1 or 2 line improvement was there afterwards, but it was not improving very significantly. So, afterwards we like dilated him and we saw that there was some part of cortex was there. So, we went for a secondary cortical aspiration, and after that the patient had
Infection.
initially first day he had good vision and everything. After 2 days he did not even have that much pain, but he just suggested that I am having lesser vision. He just complained that yesterday I had, probably he didn't have any trauma also, nothing was there, but he just said that vision is somehow a bit less comparatively, as he felt.
So what is your question?
So the question is that only that he might, like when we took the tap and everything, so P acne came. So that would have been like when the secondary intervention would have been done, then it would have been released, like the
See-
exudates are also there.
Yeah, the nidus would have been,
Yeah.
Sir, please.
Yeah. Yes, Nirmal.
yeah, the nidus would have been there during the first surgery, and the second procedure probably aggravated that.
Yeah, that's a reasonably. You see, P. acne sometimes I have
the
seen
capsule.
normal patient. Yeah, because the nidus is generally in the capsule or around that area. Sometimes we have done YAG and gets precipitated. Like in your patient, most likely the nidus was there. You did the second intervention and it got precipitated. So most likely that is the reason. So in the such situations, you have to act vigorously because its response to Vanco pretty okay. Because Vanco is the vancomycin, he will respond. Yeah.
You give intracameral moxifloxacin during the second procedure.
So that is, we'll talk about that perioperative measures by Rajesh Sinha. So because time is pretty less and yes, Rajesh.
Yeah.
Because he's going to talk about, you see, pre-operative, per-operative and post-operative, because everybody has a different regimen. Nobody follows this, So Rajesh will tell us what he does.
Yeah.
Rajesh, we know, is the honorary treasurer of AIOS, and more than that, I think he's an excellent clinician. You see surgical videos, you learn every time. So very nice videos he shows, and he's primarily interested in cataract, secondary IOLs, refractive surgery.
Thank you, sir, and a very good afternoon to all of you. I'll be a very nice presentation on how endophthalmitis should be treated and how it could be detected. But I'll be talking about what all we should do in order to prevent it. So I don't have any financial interest, and so there are various risk factors that are involved in causation of endophthalmitis, and risk factors can be preoperative factors related to the eye of the patient, lid of the patient, etc. Some intraoperative measures that we have taken, some infection can go through the instruments, some solution, etc. And of course post-operative as well. So as I said, there are certain preoperative factors, like if there's an infection in the lid, if in conjunctiva, and the patient has undergone any infection, any nidus is present, and the patient has undergone a surgery, then that is definitely a risk factor. High blood sugar, uncontrolled blood sugar, it further aggravates, because normally you do have some normal bacterial flora, etc. in the eye, which may be there, but it may not get very prominent. It may not become very dominating if the local immunity or the systemic immunity is not is proper. But because of high uncontrolled blood sugar, this happens, and then the growth of organism increases, and that flares up the infection actually. Then there are certain preoperative preventive measures that we should take, that whenever a patient has to undergo cataract surgery, a thorough evaluation of the lid and a nexa should be done. That is the area from where the infection goes the maximum. The coagulase negative staphylococcus is the organism, which is the most common organism, that is present as a commensal. So that is a big issue, and that can result in infection. Then of course regurgitation test is normally done everywhere and anywhere. That should be emphasized, that it should be done. Then no contact procedure should be done on the day of surgery. That is very essential, because the infection can pass on from any object. And then of course starting prophylactic antibiotic is something about which I will again discuss. Then other things have to be evaluated, blood sugar has to be controlled, and other systemic evaluation should be done. Now coming to pre-operative antibiotics, the idea is to decrease the load of the microbes in the cul-de-sac, that is one, and that is basically as a prophylaxis. Now this prophylaxis, whether it should be given for a long period before the surgery and or not, that is a big question. Now earlier, a few years back, there was a recommendation that we should start the antibiotic 3 days before the surgery, and that is essential. That was the international recommendation, and that everyone was following. Now these days there's another concept that people feel that if you give too much of antibiotic, there's risk of resistance, and all those things are there. Whether we require any that much of prophylaxis, or maybe a single day prophylaxis is needed. A lot of debates are there, different opinions are there, but now most of the people feel that 1 day of preoperative antibiotic is appropriate, because that is basically for prophylaxis, and that is appropriate. Now, apart from obviously antibiotic, I'll be discussing other things as well. So which antibiotic to use? Well, one should use a broad spectrum antibiotic, and one should use a bactericidal antibiotic. One should never use a bacteriostatic antibiotic, because that will cause further problems, resistance, and all those things. So fluoroquinolones are the ones which are very often used in taking care of this. Then of course other general measures should be taken. You should take consent of the patient, and high risk and everything. Pulse oximeter should be done. The sterilization of OT should be maintained. That is very important. Then sterilization of instruments. plus sterilization of instruments in between procedure, that is again a very important thing. And what you should do, that you should document. These days, now there's so much of issue of court cases and litigations and all that. So you should have a proper documentation and a photographic documentation of everything, that sterilization was done, this was the color change of the indicator, and all those things should be done. So that is, documentation is the key. If you have not documented, that shows you have not done. That is what is implied in a court of law or by anyone. So documentation is the key. OT layout should be as per the guidelines. I will not go into details of it. Sterilization should be done, proper mopping and all the methods should be followed in order to sterilize the OT. The instrument should be sterilized, the high-speed sterilizer, you can have plasma, you can have autoclave, all these, in order to sterilize the instruments in between cases. That is most important. Because we always operate multiple cases, and in between cases the issue comes, and then there can be, infection can go on and on in multiple cases. As far as surgeon scrubbing is concerned, one should definitely scrub it very properly. One should follow proper rules as far as scrubbing is concerned. At least 3 scrubs with a solution equivalent to 4% chlorhexidine for at least 3 to 5 minutes after under the tested running water. And ideally speaking, a clock should be placed in the washing area to actually see that yes, you are washing it properly for a proper period of time. And after washing, the hands should be above the waist. The hand should always be elevated. It shouldn't be down, otherwise the solution, the fluid will trickle towards your hand, and that is not acceptable. So it should drain away from the hand. So that's why the hand should be kept up. That is important. Then 10% povidone iodine should be used for surface painting and cleaning, and 5% povidone iodine solution should be used in the cul-de-sac and kept for 1 minute. Now, there was one study in BJO wherein they said that a double contact of 5% povidone iodine between for a gap of 10 minutes. Like you do it once, wash it, and then again after 10 minutes you take the patient to OR and then again put 5% povidone iodine and keep it for 1 minute and then remove it and then start the surgery. So double contact reduces the organism further, but I feel still most of us and most of the guidelines, they don't emphasize too much on that. That is just one study that I have come across. But most of the basic idea is that 1 minute of povidone iodine 5% in the cul-de-sac is the key to prevent infection. That is the most important thing. You can leave aside all the pre-operative antibiotics, etc. And of course, meticulous lid draping, because lashes and etc. all should be properly draped so that it should come under the drape. Then, of course, the irrigating solution, etc. should all, whenever you are using it, there should be there are certain specific guidelines. Like for irrigating solution, you use transparent flexible bag or in bottle container, and you should always check the bottle for any suspended particle in it, or whether there is any leak or not. So that is very, very, very important. And you should always record the batch. When you are using, one day you are using one batch of fluid, you should always take a photographic picture. You should always keep a record, always keep a solution. Ideally speaking, you should keep a solution of that, sent for culture as well. But you may not do it every day, but you should always retain the documentation related to the batch of the solution. That is most important. And viscoelastic should be used in one patient, and it should be finished. It should not be reused. And of course, as I said, the batch numbers have to be checked repeatedly of everything, like for the viscoelastic, for solution, for everything. And a lot of buzz is going on regarding intracameral antibiotics, and there are studies which have shown that intracameral antibiotics, cefuroxime was used in, it was reported in ESRS 2007, long back, that intracameral ceftriaxone prevents endophthalmitis to a great extent, 5-fold reduction in endophthalmitis. Then people started using moxifloxacin, and moxifloxacin, unpreserved moxifloxacin is something that one should use, not the preserved moxifloxacin, and that can be used. And this is one study by from Arvind group by Dr. Harpriya et al., which have reported. We are also doing a multicentric study, and a huge number of patients have been already done. So in this study, they concluded that intracameral moxifloxacin causes a 3.5 times reduction in endophthalmitis rates with the use during the surgery. And that is why these days most of the people, majority, not all, but majority of the people are using intracameral antibiotic at the end of the study, at the end of the surgery. And this is one study which was related to guideline, like, what kind of surgery resulted in more chance of endophthalmitis. So people saw that, the clear corneal incisions had a slightly more chance rather than scleral tunnel incision. Then some IOL related also stuff was seen, that silicone oil had more adhesion of, it is a known thing that silicone attracts adhesion of all these molecules and all these microbes. So they reported that 3.13 times the risk of endophthalmitis was higher if silicone oil IOL was used. But these days we are not using silicone IOL, so that is absolutely, that doesn't carry much meaning. As far as post-operative treatment is concerned, we normally, most of the surgeons now are doing topical surgery under topical anesthesia. So we don't do patching. But what I advise is this, that patient, after doing, it's a daycare procedure. So you do patching till the patient reaches home. And after that, he can remove the patch. So that will be an extra protection in order to prevent dust and dirt and infection going into the eye. And topical antibiotics we use for 10 to 14 days, and topical steroids for nearly 4 weeks. And we don't use systemic antibiotics, and that is also not recommended. In very, just for the sake of completion, it is always said that systemic antibiotic is used in high-risk cases. But the proportion of that high-risk case is very minimal. And the first week is essential. Why? The first 24 hours are essential, and then first week is essential as far as the follow-up is concerned. That's why we follow up on day 1 and day 7, and then after that 1 month. If nothing is there, on day 7 you can ask the patient to report if he has any symptom. Otherwise, he may not report as well, and the patient can come directly after 1 month. So the idea is that the patient should be educated regarding this thing, that the risk of infection and the risk of all these symptoms are more likely in the initial post-op period on up to day 1 or maybe up to day 7. So you just have to be a bit careful. As far as camp surgery is concerned, if you are doing camp surgeries, then there are certain recommendations based on our own AIOS guidelines that we should not do more than 25 eyes per surgeon per session of 4 hours. Now these days surgeons can do very fast surgery, but that doesn't mean that the surgery can take even lesser time, but the measures to prevent infection should take more time, so that the patient does not have any infection. And combined surgery should be avoided. Then topical surgery should be done, or high-risk surgery should be done only by experienced surgeon with due precautions. One-eyed patient should be avoided in mass surgeries. Unless he's a hypermature cataract, then you have to take all the precautions, use your best surgeon, use your best equipments, etc. And there should be dedicated OT and no makeshift OT. And as I said earlier, that the commonly isolated microbes are the coagulase negative staphylococcus, which is already there as a commensal in the cul-de-sac. And I won't go into the post-op acute endophthalmitis, very nicely presented by Dr. Avninder. So what I would like to conclude here is that prevention is definitely much better than cure, about which even the best of retina surgeons, we have Avninder here, we have Dr. Nirmal here, and others as well, they will all agree that preventing endophthalmitis is a better tactic rather than thinking about treating it. Obviously, we have to treat once it is there. And most of the infections are due to contaminants or due to commensals. They are present in the eye, or they are contaminants through the solution or through the instruments, etc. So these things should be prevented. As far as lid margin and cul-de-sac is concerned, betadine, povidone iodine should be used to take care of that. And for the solution and instruments, you have to maintain proper sterilization. Look at the solution, as I said, look for suspended particle, maintain a record of the batch. So all these measures should be taken, and as I said earlier also, documentation of all the measures taken should be there so as to prove that you have done it, because if not documented, that means it's not done. So that is the most important point as far as your safety and of course patient safety is concerned. Thank you very much.
Thank you, Dr. Rajesh. That was the most comprehensive lecture on pre-operative and post-operative protection.
Thank you, sir.
Thank you so much for it. So maybe you can take some questions from the audience. Yes.
I've got two questions. The first one is, the preloaded ions, do they have any benefit for preventing like endophthalmitis? Because you mentioned the method of insertion as no role. The other one is
That was one study actually. Method of insertion had no role, but
because
yeah.
by counseling patient we tell as an extra advantage to the patient. So
See, there's no study comparing preloaded versus not, loading. But the thing is that logically, preloaded ones should have less chance of contamination, because when you are loading, then also you are using multiple instruments. There is a key, my teachers at RP Center, they always said that the key is that use minimal instrumentation. So minimal instrumentation will have minimal chance of transferring infection. So the preloaded ones are already loaded. They are there in the cartridge, they are there, and they have been sterilized. So the risk of contamination during loading is not there. So theoretically, definite advantage is there, but there's no study, comparative study, based on which I can say that yes, it shows that it is there. But logically appears to be yes.
The exposure of the IOL surface is restricted in preloaded. And second, you are not exposing the lens to the surgical environment.
Yeah.
Because very often when we handle too many instruments, they can be cross-contaminated already. And if you use the same instrument, so that we have seen during loading the IOL, some cotton fibers or certain materials stuck onto the lens, viscoelastic. So this can act as an IDUS. So we are preventing in a way both theoretical as well as reducing the surface contamination.
okay. And sir, do we have to use glass bottles autoclaved or the BSS commercially available? Which one should we follow?
See, actually it is said that the best solution is the BSS Plus in the plastic
No, but
container.
in the end of point of
And,
view, because
yeah.
in between, like I remember, I discontinued one of the company's BSS because I heard that like it is risky and the batch came out.
Actually, it is
No,
with
this
everything.
is a big
certain
debate.
batches.
Okay, but from the pharma point of view,
Yeah,
so you
but
concluded
it's,
your question?
Playing safe, like autoclaving yourself, the glass bottles to tell.
Okay, so you are opening up a Pandora's box, right? So we are suspecting the entire pharmacological supply chain system, right? So we have to believe that in PVC, there's no added advantage of autoclaving. And same way in glass, there have been a lot of pharmacological industry-based studies that the glass bottles doesn't offer any added advantage. In fact, there is a risk of contamination when you are autoclaving because the cap, mostly it is a polyvinyl thing.
Yeah.
So by heat method, it's expanding, and if there are micro openings, there is an added risk of contamination. Second thing, you are, by autoclaving, increasing the temperature, you are altering the pH of the solution. So this, in fact, can induce a TAS. So when you alter the pH, so it is neutral pH, the solution. When you alter, RL or BSS are thermolabile. It can affect the composition. So the bicarbonate part can evaporate. So you are altering the pharmacological composition of compound lactate, which we are not supposed to do. So generally, the pharmacological expert doesn't advise added autoclave in your system unless you suspect something and then you want to be doubly sure. So that only gives added safety and maybe a good night's sleep. But I don't think from the endophthalmitis point of view, it adds anything.
So if she suspects, she should not use it. Why autoclave and still use it?
Exactly.
Throw it.
Throw it. So trust your pharmacological, and main thing, have an eye on the supply chain management and where your people store the PVC or glass bottles.
So sometimes some small fiber gets into the anterior chamber post-op. Next day we see it. Should we go after it vigorously or keep quiet and pray?
Keep quiet. So many of these all sterile fibers.
Periodically see the patient.
Yeah.
Till at least 1.5 months.
Right.
Nothing happens after 1.5 months, it will not work.
Rajesh, I have a question for you.
Yeah.
Since you are doing a multicentric study,
Yeah.
with the rampant use of moxifloxacin intracamerally, what is the risk of antibiotic resistance to moxi? Because that's the only drug we have now, a potent drug. The next antibiotic is not in the, it's still in the pipeline, does not come to the clinical picture.
True.
Are we overdoing ourselves by doing this?
Yeah, actually, I always felt that we are overdoing it, and but the trend now, because of the litigation factor, I mean, I always felt, because for only last few years I have started using intracameral antibiotics, moxi, but otherwise, I mean, till 3 years before I was not using it, and many people were using it. So I always felt that we are overdoing it because the risk of resistance will be high. And I agree with you. I mean,
Because it's a huge numbers.
True,
We are doing
true.
surgery in millions,
Yeah,
and
yeah.
this exposure
Yeah.
can lead to resistant strains.
absolutely, that is very true. I completely agree with you. I mean, that is why initially, pre-operative antibiotics were, when it started with a longer period. Then people told that don't use it too long, otherwise there will be resistance. Similarly, for so much rampant use of intracameral moxifloxacin, the risk of resistance, development of resistance is really high. That is very true. That
So
cannot
what would be
denied.
the alternative in case moxi develops resistance?
Maybe like people who have used cefurexime, that is not very commonly used, at least in ophthalmology. Maybe systemically people have used, so that may be one option, and that is safe as far as intracameral use is concerned. So that may be one option.
Because most of the time, vancomycin we are limiting because that was the only drug available
Only,
for
yeah.
intravitreal usage. Same
Intravitreal
way,
as
should
well
we
as-
initiate some
yeah.
proper guidelines to limit the use of intracameral drugs only for high-risk patients?
I completely agree with you. The only thing is that when we do all these multicentric trials, what happens that we do thousands and thousands of cases, and there can be some confounding factors also, which might have caused. And there's the number of endophthalmitis is not high, but still, if there are 2-3 in one group, that confounds, or there may be some other factor as well. Maybe betadine was not used properly. So many factors are there. I completely agree that the risk of resistance is high if we use intracameral moxifloxacins so much. And at this point of time, moxi is used systemically as well, and that is also one reason why the risk of resistance is higher with moxifloxacin. And what vancomycin, what you are telling, the same we follow when we treat corneal ulcer patients also, because we don't use vanco routinely because we keep it as a reserve drug for those. Dr. Namta, can you just? Yeah. Can you connect?
Have 2 more minutes.
We were just waiting for
We can
you,
give
and we were buying time.
Yes.
We were discussing.
So welcome Dr. Namrata Sharma. She don't need any introduction to this August gathering. The honorary secretary and the multifaceted personality of All India Ophthalmic Society.
Thank you.
Over
Thank
to you,
for
Dr.
those
Namrata.
kind words. I think this is a very important topic today on endophthalmitis, and I will be talking to you about intracameral antibiotics for post-operative endophthalmitis, more so from the results of the study that we have done on almost 16,000 patients now. So I think all this must have been already talked about, and so I will not go through this again. Intracameral antibiotic prophylaxis has already been studied. Various drugs have been studied like cephalosporins, vancomycin, moxifloxacin. ESCRS study which did strongly support the use of intracameral cefuroxime, but it is not available. And vancomycin, which used to be used earlier, does cause hemorrhagic occlusive vasculitis, and so it is not used. Moxifloxacin is one drug which is used, and I think it is now available in injectable forms from two companies with no financial interest in any of them. One is the CIPLA and the other is Alcon. The bactericidal levels are maintained for longer duration at clinically administered dose following intracameral injection of moxifloxacin, and this is well proven by Arshinov. And in vitro comparative models have also been studied. And this is the published literature, and I think there's huge amount of literature which is there which says that moxifloxacin is safe and it is effective and can be used for intracameral prophylaxis. Now, this study was retrospective, although it looked at 9 lakh eyes, and the results favored intracameral antibiotics at the end of cataract surgery, with no difference in the efficacy between intracameral and topical antibiotics versus intracameral antibiotics alone. And this was yet another study which looked at cataract surgery over 1 lakh eyes with no IC prophylaxis, over 1 lakh eyes with prophylaxis. But important thing to note in all these studies is that these are retrospective studies and there are no prospective studies. I know of ESCRS who was wanting to do this kind of a study with 75,000 patients, which was planned as a multicentric trial but did not happen because it was very expensive to do it in such studies are expensive to do in US and in Europe both. So we did a randomized control study, and there were some gaps also in the study because of the COVID. But this is a prospective evaluation of intracameral moxifloxacin for prevention of post-cataract surgery endophthalmitis. And the study was started before COVID, so we calculated the sample size of our center, and we also included Sadhguru Netra Chikitsalaya Chitrakoot to get that huge sample size, because otherwise it is very difficult to get a huge sample size. And so in group 1, phacoemulsification was done, followed by intracameral injection of moxifloxacin 500 microgram per 0.1 ml, and in group 2 routine phacoemulsification was done with no intracameral antibiotic alone. It was difficult to actually convince people and convince surgeons not to use because some of them were routinely using it. And secondary objective was also to look at the effect of moxiflox on the corneal endothelium. So in terms of the mean age, gender distribution, the type of cataract, both the groups were well matched. And in terms of logmar visual acuity, there was a difference in visual acuity because of the grade of the cataract that was there. And that is why the pre-operative visual acuity was significantly different in the two groups. But then when you're looking for prevention of prophylaxis, I think that really should not make a difference. Rest all of the parameters, the incision size, type, location, IOL optic, IOL haptic were similar for both the groups. So also was the IOL position, IOL type, IOL insertion method, and wound closure, as well as whether posterior capsular rupture was present or not. There were complications, and that sub-analysis we have to do what happens in the cases which are complicated. But overall, when we looked at the visual acuity, the IOP post-operatively, and endothelial cell density, as well as CCT and systemic adverse events, there was no difference between the two groups, which means to say that moxifloxacin is quite safe as far as the endothelial health is concerned, and so is the intraocular pressure and CCT. In terms of the mean intraocular pressure, endothelial cell loss, and central corneal thickness post-operatively also, it was found to be similar in the moxifloxacin group, and as expected, the visual acuity was better. In the control group also, as expected, the visual acuity. What happened? It's flashing here, but
yeah.
So overall 16,000 cases, 8,000 in each group, and number of cases with endophthalmitis was 38. In the moxifloxacin group, there were 14. In the control group, there were 24. And none of the patients developing endophthalmitis had intraoperative PCR in either of the two groups. So no ocular or systemic adverse events were reported with intracameral moxifloxacin. So if you look at that way, this is perhaps the first randomized control trial which has looked at such a huge number of subjects, and has clearly shown that in those cases where you do give intracameral moxifloxacin, the endophthalmitis rates are much less. Another thing we just looked at was, because this is preliminary analysis, and for this presentation we had to do it, but we are doing a subgroup analysis also to see other intraoperative complications when they are there, like iris prolapse or like dialysis, etc. What happens in those cases between the two groups? But as far as this study was concerned, none of the groups had PCR who developed, or none of the cases had PCR in either of the groups who developed endophthalmitis. So I think this is a robust data, mainly also because it's from two tertiary eye care centers, and it is a prospective data. So we don't have such a huge sample size prospective study. So possibly when we do a detailed analysis, we would come out with more recommendations and more findings. So thank you very much for your kind attention.
Thank you, Dr. Namrata. So we have to conclude the session, and I thank all the speakers and our chairperson, Dr. Lalit Verma, the current president, speakers, Dr. Avnindra, Dr. Namrata, and Dr. Rajesh for joining us and making this interesting session lively. And also the audience for making it a lively and interactive session. I hope it was useful to all of you. I thank CIPLA for sponsoring and helping us with this session. Thank you.